Rapid extubation protocol. This PowerPoint presentation will introduce the Rapid Extubation Protocol, a new quality improvement process. I will review how this protocol aligns with our organization's mission, vision, and values. I will also discuss how the needs assessment was used to discover the deficiency of delayed extubations within the CVICU. I will review the protocol concept along with the goals and outcomes after implementation. I will discuss stakeholders' reactions to the new protocol, along with how I plan to sustain the process in the long term. I will review the AONL concepts and goals I hope to achieve by implementing this protocol. The mission of the healthcare organization is to provide high-quality, patient-centered care that is built upon evidence-based practices. This enables the organization to improve health outcomes and improve patient experiences. The organization also utilizes stakeholder collaboration and a culture built upon respect and innovation to achieve these goals. The vision of the organization is to create healthier communities now and for future generations. The values of the organization include compassion, credibility, and courage. The process improvement developed and implemented within this organization speaks to these values as it will illustrate their devotion to safety and quality service while caring for the patient with kindness and respect. This innovative process change will bravely demonstrate their initiative to improve patient outcomes and experiences. The organization also received redesignation as a magnet facility in 2023. Magnet facilities are recognized for quality patient care, nursing excellence, and innovations in nursing practice. Magnet-recognized facilities also have a higher rate of nurse-physician collaboratives and safer work environments. This organization has also achieved the goal of being deemed a high reliability organization. This designation includes being 100% compliant with evidence-based practice, reducing preventable patient harm to zero, and searching for cost-effective methods to improve patient care quality. The rapid extubation process improvement is another example of how this organization develops and implements performance improvement at the bedside. Enhanced recovery after surgery protocols have been extended into post-operative cardiac surgery areas. A hot topic for debate is the appropriate time for extubation for a patient undergoing coronary bypass graft surgery. The Society of Thoracic Surgeons has defined early extubation as occurring within 6 hours of arrival to the intensive care unit after cardiac surgery. The current goal for extubation time in the cardiovascular intensive care unit is less than 12 hours, which does not align with the current evidence-based safe practice of extubation time of less than 6 hours. Conducting a needs assessment within the healthcare organization involves obtaining and analyzing data that can be used to improve processes within the unit. In this case, it discovered a lack of consistency or performance gaps between the provider's workflow and communication during the recovery of CABG patients in the CVICU. The quality improvement process of developing a rapid extubation protocol will be used to address this deficiency in the standard of care. The assessment will identify the training and skills necessary for the team to implement this new protocol. Metrics to evaluate and measure the success of the rapid extubation protocol will be established. The SWOT analysis assessment determined the need to change extubation protocols within the CVICU. This tool identifies a healthcare organization's strengths, weaknesses, opportunities, and threats affecting process improvement. The strengths or benefits behind implementing a standardized extubation protocol include the potential for reduced length of stay in the hospital, which can contribute to lower healthcare costs. Other strengths in the protocol included the patient's ability to resume diet and mobilization earlier, contributing to increased patient satisfaction. Weaknesses that could be barriers to implementing the process change included a lack of consistency in the steps used to determine patient appropriateness to extubate and staff resistance to early extubation. Reasons discovered for resistance included the use of narcotics needed to control post-operative pain, which contribute to the patient's difficulty staying awake and increasing the risk of CO2 retention. Other barriers included the availability of critical care physicians and respiratory therapists due to shift change or other patients that needed their attention. The opportunity will be to decrease extubation times to less than 6 hours for post-op CABG patients. This multidisciplinary team will include surgeons, anesthesiologists, critical care physicians, respiratory therapists, nurses, patients, and pharmacy. These stakeholders are crucial to the success of this process. A threat to the success of this process improvement includes the potential for poor communication among these team members and a lack of adequate staff training on the new protocol. The Rapid Extubation Protocol will be a process improvement project that provides standardized care to eligible CABG candidates. The protocol will help staff care for post-op CABG patients more efficiently, enabling the patient to receive high-quality care through its implementation. The needs assessment identified provider practice patterns, staff resistance, and workflow as barriers to attaining the goal of extubation within 6 hours. This protocol will utilize evidence-based practice to provide consistency when caring for post-op cardiac patients, which has been proven to positively impact patient outcomes. The protocol will use a tool designed by the multidisciplinary team to track the patient's progress toward extubation. Communication and collaboration among team members are crucial to the success of this process change and extubation of patients. The handoff tool will guide the multidisciplinary team and ensure the designated tasks are carried out within the specified timeframes. This form will assist the staff in providing standardized care and is a checklist to prevent crucial tasks from being missed, which will help the staff meet the goals of extubation within 6 hours. Each staff member's task will be clearly outlined, and the pathway will trigger a succession of events leading to the successful extubation of the patient. For example, the tool will state when the sedation will be weaned off and when the ventilator will be weaned to progress as the patient tolerates. Protocols such as this have been found to be safe and effective and can facilitate the early extubation of patients. The protocol empowers the respiratory therapist and nurse to continue along the pathway as each step is successfully achieved and triggers the early notification of providers upon finding barriers to early extubation. The early extubation of CABG patients can decrease the occurrence of ventilator-associated pneumonia, lower healthcare costs, and potentially decrease patient length of stay. The performance data will be collected from the handoff sheet and the electronic health record. Information collected will include patient demographics, type of surgery, lab and arterial blood gas values, hemodynamics, barriers to extubation, and extubation time. We will also gather data regarding the providers caring for the patient. We will meet weekly initially to review the data and make changes to the new process as needed. This quality improvement process will develop and provide staff with a valuable tool for the rapid extubation of post-op CABG patients. The form will include the criteria for suitable candidates for early extubation, including hemodynamics, gas exchange, and hemostasis. Such checklists have been successfully used previously and can contribute to the cohesive care of the patient. Once the requirements are met, the standardized process will be able to be implemented by nursing and respiratory staff. The trigger of the phrase fast track will help staff identify appropriate candidates earlier and start the process quicker. The process will include specific time intervals for tasks to be completed. For example, the sedation will be turned off at 60 minutes if all other criteria are acceptable. Having a preset time assigned to this task helps to prevent missed opportunities for rapid extubation related to the patient being drowsy. The standardized process also clarifies the respiratory therapist and nurse's roles and actions that must be performed on time to achieve successful patient extubation. It also improves communication between the critical care doctor, surgeon, and nurse caring for the patient, as it has designated time intervals to communicate with the providers. This also enables early identification of barriers to extubation and allows the provider time to try to correct the barrier. For example, if the patient is taking rapid shallow breaths due to pain, the provider can intervene and order appropriate pain medication to help the patient breathe deeper and at a slower rate. The protocol does allow for documentation of why the patient failed to be extubated within the 6-hour time frame. As a leader, I must design and implement pathways such as this to positively impact the outcomes of the postoperative CAP patient. The project compared the 25 CABG cases that occurred during the post-implementation and 25 cases performed immediately before using the new protocol. The rapid extubation tool was successfully utilized to facilitate the extubation of 18 patients within the 6-hour window. This was a 72% success rate compared to a 56% success rate prior to the implementation of the protocol. The 25 cases reviewed prior to the protocol illustrated that 14 of the patients were successfully extubated within the 6-hour time frame. Delays to extubation were attributed to sedation not being discontinued early, larger doses of narcotics being used for pain control, and a lack of communication between staff that the patient was ready to extubate. All of these patients met the criteria for rapidly extubating, including appropriate body mass index, relative comorbidities, hemodynamic stability, and procedure type. After implementation, the staff was able to follow the outlined task easily within the proper time frames to extubate these patients successfully. The nursing staff was able to wean off sedation at the appropriate times, and the patients received a multimodal pain management regimen to help minimize the usage of narcotics during the weaning process. The respiratory therapist was able to follow the protocol and perform successful ventilator weaning and spontaneous breathing trials to ensure the patients were ready for extubation. One patient fell outside the 6-hour window due to a shift change of staff, delaying spontaneous breathing trial. This will be addressed at the next meeting, and suggestions to perform bedside reports or to have a designated full-time CV-ICU respiratory therapist will be made. 3 failures were attributed to staff and equipment failure. The respiratory staff were using a new tube securement device and trapped the balloon to the cuff in the holder itself. 3 patients did not have the appropriate positive cuff leak required to extubate until the error was discovered the next day. Respiratory therapists will receive education again on the proper usage of the new endotracheal holders, and other staff will be made aware of this potential barrier. The surgeons deemed 3 patients inappropriate for early extubation after the process was initiated. The process was halted due to postoperative bleeding in 2 of the patients and cardiac arrest in the last case. The respiratory therapists, nursing, critical care physicians, anesthesiologists, and surgeons collaborated to create the evidence-based rapid extubation protocol. The teams shared knowledge and recognized each other's capabilities while creating a policy that would achieve high quality and safe care for these patients. Surveys were used to obtain feedback from the stakeholders after the protocol was implemented. The protocol created a positive work environment, improved communication among the providers, and engaged staff to be active participants in the process. Patients who experienced this protocol were satisfied with the removal of the endotracheal tube early, but were dissatisfied that they were only allowed clear liquids till cleared by speech therapy the following day. They were able to talk and interact with their families sooner, though, which is a positive. The endotracheal tube and ventilator can be intimidating to families, so the removal early was a relief for them. Initially, the respiratory therapists were puzzled upon implementation of the protocol due to their lack of education about the expectations or duties they had to perform within each given time frame. Each department was responsible for educating its own staff, as this protocol crossed over multiple disciplines, and its educator failed to perform this duty on time. The nursing staff embraced the protocol as it empowered them to follow the steps and extubate patients who met the criteria sooner. The paper handoff, which contained the parameters to be met and staff documentation of labs and barriers to extubation, was seen as duplicate documentation. The patients labeled as fast track triggered the staff to use the rapid extubation protocol and perform an early assessment of the patient's appropriateness to follow this pathway. The protocol improved interdisciplinary communication, as there are assigned timeframes that include communicating labs, hemodynamics, and patient progression with ventilator weaning to the appropriate provider. The providers did appreciate the staff independence to proceed with ventilator weaning if criteria met, which decreased the amount of phone calls received. The culture of magnet facilities is one of empowerment, knowledge, innovation, and improved patient outcomes. The CVICU has a well-educated workforce that creates a better work environment, which leads to better patient outcomes. These employees are empowered to influence decisions that affect the care and outcomes of their patients. They also have the opportunity to apply new evidence and improve processes through innovation to lead better outcomes. The rapid extubation protocol will be included in new employee orientation and annual skills checkoff for staff. This protocol will become the standard work as it is supported by best practice evidence for extubation. Improvement huddles will occur weekly to review documented reasons staff could not extubate within the time frame. This will help identify barriers so that the protocol can be modified to achieve the goal of extubation within 6 hours. These huddles promote communication among staff members and keep them engaged with the process. This reinforces the protocol and keeps staff up to date on any changes to the protocol. By doing this, leadership can prevent burnout or disinterest in the protocol, as frontline staff will be included in these huddles. Performance boards placed on the unit will provide a visual illustration of the outcomes of the protocol so that staff may review the success they have accomplished. The continued tracking of key performance indicators identified in the process also aids in embedding this new protocol into the staff's daily operations. This will reinforce that this is the best practice for extubation for post-op CABG patients. During this quality improvement process, I wanted to achieve the 3 American Organization for Nursing Leadership competencies: communication and relationship management, knowledge of the healthcare environment, and leadership. The goals I set for myself included fostering new relationships to meet my goals, developing a new evidence-based pathway, to provide improved outcomes to our patients, and moving my vision into action. I learned to communicate clearly with all stakeholders, building a trusting environment in which I can build a collaborative team. Through this trusting relationship, I gained the cooperation of the other stakeholders, which enabled me to accomplish my goal of rapid extubation protocol. We were able to use evidence-based practice to create a protocol that is safe and patient-centered. The other invested stakeholders could share this information with their departments, encouraging buy-in to the new process. My knowledge of the healthcare environment enabled me to present patient care issues to the interdisciplinary team. By sharing these issues, we were able to use evidence-based practice to develop a new protocol to extubate patients safely within the 6-hour time frame. This displays my ability to use data to problem solve and make appropriate clinical decisions. This new practice aligns with my organization's values of providing safe, high-quality care to those we serve. My leadership competency involved practicing ethical behaviors and self-reflection on how my beliefs and values impact my decision-making. I learned to delegate tasks to the appropriate team members as a leader. As we have a magnet culture based on innovation and transformation, the concept of the new pathway was agreed upon early in the quality improvement process. We were able to identify barriers to extubation and generate a solution, which was a standardized extubation protocol. By sharing my vision with others, we could move into action and develop the new process. This also aligns with the organization's mission to improve health and vision to create healthier communities for today and the future. The ability to define failure and determine the root causes of why our extubations failed to meet the safe standard of under 6 hours led us to identify the gaps in cares. This led to the creation of an interdisciplinary team and the quality improvement process of developing a standardized rapid extubation protocol. Many disciplines contributed to this protocol, which enabled us to extubate our patients safely within the designated time frame. Without all of their contributions, we would have failed. The project required transparent communication between the stakeholders to ensure the process met all identified areas of improvement. Education on the process change is essential to a smooth rollout, and the next time I will verify that all departments have been formally educated on the process. As a leader, I will continue to build relationships that will support our culture of innovation and the development of evidence-based methods.